Welcome and good evening. Thank you for joining us for our presentation. My name is Michelle and I'm the program coordinator at Waterford Place Cancer Resource Center. Waterford Place provides programs and services free of charge for anyone impacted by a cancer diagnosis that support whole person care. I'm pleased to introduce our speaker for this evening, Dr. Amy Siston. Dr. Siston is a licensed clinical psychologist who works at the University of Chicago Medicine in the Department of Psychiatry and Behavioral Neuroscience. She specializes in psycho-oncology and was integral in building the psycho-oncology service at the UCM, where she provides individual therapy to cancer patients. Additionally, she is an American Association of Sexuality Educators, Counselors, and Therapists certified sex therapist, and also provides sex therapy to cancer patients and their partners. At this time, I'm going to let Dr. Siston begin the presentation.
Hello, thank you very much, Michelle, for the introduction and kind words. Welcome everyone. What a great opportunity we have to present this lecture via the video format. No one wants to be out tonight, and more than likely this event would have been canceled with the weather being so bad. So that's one thing we're really saving on these days in everything we do. Are the snow days can be done from home. So this is a great opportunity then to talk about these issues together. So what I'm going to do is present on some of the more common sexual difficulties that patients present with. Some treatment approaches that I generally use, and hopefully we'll have some good discussion at the end. Please feel free to ask any question. I'll do the best I can to answer that. So with that, I'll go ahead and get started then. So what do we know about sexual function, especially as it relates to cancer? What we know is that 40 to 100% of survivors experience some sort of sexual difficulty during or following cancer treatment. 40 to 80% of those who are younger will report distressing sexual side effects, and 50% of younger women will report problems in at least 2 or more areas of sexual function. The majority of survivors report that not receiving support for sexual problems in the context of cancer. So basically, they're not getting the help that's needed. Most individuals are saying, no one's asking these questions. What can we do? The most commonly reported sexual issues pertain to issues of desire or low libido, with about 25 to 60% of individuals reporting this issue. Sexual arousal, with 24 to 60% reporting some difficulty with being sexually aroused or being able to self-lubricate. 27 to 38% difficulty with orgasm or climax. And 29 to 40% of individuals reporting pain or pain with intercourse. So what do disorders of desire look like? So that's basically, I'm not interested in sex. I feel flat. There's nothing there. Nothing's the same as what it used to be. And what contributes to this? What do we know? Typically medical treatment, chemotherapy, hormonal therapy, contributes to abrupt and early menopause for those that have not been in menopause. Things like fatigue, if you're tired from treatment, and this is a fatigue that is very distressing. Your libido is also going to be low. If you're not feeling well, if you're nauseous, for example, libido is not going to be present. What also contributes is how we feel about ourselves, our sexual self specifically. Do we feel attractive anymore? If we've lost our hair, we have scars, we've lost or gained weight, one doesn't feel physically attractive. And one can also then lose their confidence for engaging in sexual activity based on how they feel about themselves. What also gets in the way of libido or desire is how we feel emotionally. If one is depressed, often a symptom of depression is low libido, but low libido can also be a precursor for depression. Anxiety is another emotionally distressing issue, with most patients experiencing anxiety at some point during the cancer trajectory. This also interferes with desire. And also medication that is taken, like an antidepressant, to help when mood symptoms are low, can in fact alter desire even further. For disorders of arousal, women will often say, you know, what's going on down there? Why am I so dry? Or why don't I feel the same way? Why don't I get that tingly feeling I used to get? Again, much of this is contributed to medical treatment, which causes things like vaginal dryness, vaginal irritation, vulvovaginal atrophy. So actually the vagina shrinks in a way. Insufficient lubrication. So all of these things change the function and the structure of the vagina, which certainly contributes to painful sex. One experience of pain can set off a chain reaction for fear of pain, and the fear of pain, again, the body reacting to pain. I'm going to talk about that in a moment and show you exactly what that looks like. But this happens quite frequently. And sometimes it's simply changing lubrication. Sometimes it requires further treatment, like meeting with a pelvic floor therapist that will work with patients on these issues, such as vulvovaginal atrophy, to help strengthen the vaginal tissue and the muscles, and talk about different ways or different lubricants to use and what can be done to prevent some of this. So there's lots of very important treatment that come along with each one of these things. Disorders of orgasm. Why can't I climax anymore? Or I will often hear too, like, why doesn't it feel the same way? Or why does it take longer than what it used to? Something just doesn't feel the same. Again, medical treatment, psychotropic medications, antidepressants, but also medications for anxiety can get in the way of normal, or what was normal for one's orgasm. Fatigue, emotional barriers like anxiety. If you're stressed, or if you're worried that when you try intercourse again, it's going to be painful based on a past experience, your body's going to respond to that. Your body's going to prep for a painful situation, and with that will come more pain. Pain is very common. You know, it hurts. I don't ever want to do that again. It feels like needles, or I bleed afterwards. So all of these things are related to treatment, especially things like hormone suppression medication really contribute to painful intercourse by what it does in terms of side effects to the vagina, scarring, shortening. It definitely changes the structure of the vagina. Dryness, you know, and as I've mentioned, anxiety related to a painful intercourse. So let me show you what that looks like. So what happens then is women can get stuck in this cycle of pain. So you've had a painful experience in the past. So what happens is your body starts to anticipate that intimacy is going to be painful again. The body then automatically tightens the vaginal muscles. So it's almost like, you know, I'm exaggerating this right now, but there's an automatic response built into our vaginas. It will tighten. For some, it may even close, and their partners may say, oh, it feels like I'm hitting a wall. This is the body's way of protecting itself. So these muscles actually really tighten and can prevent intercourse from even happening or being extremely painful. So being tight, being non-relaxed, you know, makes sex painful, makes penetration in many cases impossible. That pain then reinforces that reflexive response. The body then reacts again by bracing. And then what happens is you may start to avoid intimacy altogether. So women will say, oh, my partner put his arm around my shoulder and I moved away very quickly. Or my partner gave me that signal that he or she wanted to be intimate, and I quickly fell asleep, or I pretended like I was asleep. I may want to, what if I want to hug my partner, but my partner thinks, okay, that I want to have sex, and that's not the case. So what do? I start avoiding that more. I start avoiding all non-intercourse or non-sexual touch, because I'm afraid that will lead to my partner wanting to have sex, and I'm not going to want to do that. I'm going to feel bad. I'm going to feel guilty. He or she is going to feel bad or guilty or be angry or just feel sad. So you start avoiding it altogether. So I say when a couple comes to see me in a therapy session, if they're sitting further and further apart, I know something is going on, and likely they've been, their sexual lives have changed dramatically. Pain may be a significant component that has led to many other emotional feelings that really affects how the relationship is at present and where the relationship is going. This cycle of pain is very easy to get caught up in. All it takes is one event of painful intercourse, and this cycle then continues to repeat itself. You can get out of it, but it takes awareness, it takes some assistance, likely from some medical professionals, and it takes convincing of oneself that you can do this. You can implement the methods maybe that have been taught or recommended, and you can actually have sex without pain. So it takes a lot of convincing of oneself too, to want to go ahead and try this. If you know something is painful or something's going to hurt, the likelihood of wanting to do it is probably going to be very, very slim. You might force yourself because somebody else is there, or somebody wants to do it. Somebody wants you to be part of it, but your body's going to just be like this and be so tense that it's going to make relaxing very difficult, and it's likely going to make sex very uncomfortable. So this is not uncommon, an uncommon event or multiple events that happen and affects individuals and couples in many ways. Another issue or a challenge is how we feel about one's body. And often what happens is a woman feels very self-conscious about how their body has changed, or it's even very difficult to look at the changes in their body, and that affects how they perceive themselves and how they believe their partner perceives them. So this is a quote, actually somebody has passed along to me, and I think it very much says what a lot of women feel. So it says, no one sees that I hate my body some days, and the simple act of getting dressed can cause a breakdown. No one sees my challenges in shopping for clothing that fit a new body, altered from surgeries, and missing the femininity that society has determined is my worth. No one sees the scars on my chest and stomach and on my soul that I hide away. No one sees me look in the mirror and comb over my thin hair to hide the scalp that chemo exposed. So I think this is an example too of how many women suffer in silence. One issue that I always really try to make sure that I address with my clients is how they feel underneath what no one else sees. Because what everyone sees from the outside, oh, you look normal, oh, you look great, oh, your body has never been in better shape. But they don't see what you're seeing here, as part of this quote. They don't see the scars, they don't see the difficulty that you may have with either looking at yourself, getting dressed, for example, putting lotion on your body. These things you never, ever gave much thought to may really take quite a bit of effort. And with no one seeing these things, there is no confirmation then that this is hard, that this is difficult. And many women then suffer very silently in terms of how they feel about their body, how they feel about their sexual selves. So these issues and more certainly can impact quality of life. When they're untreated, they're often associated with things like anxiety, depression, continued body image issues, and even women that are on hormonal therapy will discontinue treatment because of how they feel or how they don't feel, maybe I should say too, and all the changes that they've undergone. 20 to 30% of survivors will actually continue to report some type of long-term psychological problem, quality of life issue following cancer treatment. Because the good news with that most people do adjust emotionally, but the challenge here is related to the sexual side effects. They're a little bit more unique than the emotional side effects. So other treatments, fatigue, for example, anxiety, depression, these things will get better. They will get better with time. If you're a new survivor versus your survivor 3, 4, 5, 10 years out, you certainly feel different as the years go on. So many of these things get better with time, or they'll resolve with time. Sexual issues do not improve or resolve with time. This is something that will not get better. And in fact, it may worsen with time if not addressed. So why is sex important to cancer care? Well, it actually ranks among the top 5 unmet needs of survivors. So this is something that survivors want to talk about, but no one's talking about it with them. What gets in the way of this? When you're diagnosed, or when you were diagnosed, what was your goal? Your goal was to survive. Your goal was to understand what the treatment plan was. Your goal was to know when would you start, when would this be over. You had to make decisions quickly, and you had to make decisions maybe as part of a couple, as part of a family. More than likely, your sexual life wasn't the number one thing you were thinking about. Another issue that gets in the way is this kind of don't ask, don't tell policy. I definitely don't abide by that in our clinic setting. At least I try not to really encourage patients to ask your provider what might they recommend. If they brush it off, or if they say, oh, it will get better with time, push it a little bit further and ask where can you go for help? How do you know when you need help? Who can you turn to talk to if it's not being addressed with your medical provider? So asking is really important, but also is telling and being provided with that information. Another issue is this unrealistic sex expectations. So you finish treatment and everything is supposed to quickly return to normal. And things are supposed to be exactly what they were before this diagnosis or treatment ever happened, and that's not the case. Sexual recovery takes time. Sexual recovery will likely take some type of intervention. And sexual recovery is, the unrealistic sex expectations are not just for yourself, but they may be for your partner as well. Often when I'm meeting with just patients alone, I will ask their partners to come in and go through a little bit of a PowerPoint. I do it now by PowerPoint. In person, I would do it in person, but I do it more like a little bit of a PowerPoint presentation where I go through and explain what chemotherapy or what radiation has done, what side effects we can expect, especially as they relate to sexual side effects, why this is happening like this, and what would be important in terms of their role. And this is another group, partners are not asked these questions. Partners are just assumed, as supportive and wanting to do everything to help. And one thing I'll hear partners say is, I just want her to survive. I just want her to be okay. That stuff doesn't matter to me anymore. And that's great. And that's, that is very supportive. But again, as a patient, what you're not getting is someone saying, this has changed our sex life, but I still love you for who you are. Or I do really miss that part of your body, but you have a whole body to explore. So they're also not acknowledging the loss, the grieving of a body part if you've had a mastectomy, if something has changed, in regards to your vulva or something else with a gynecological cancer. They're often not acknowledging that either. No one wants to say anything. No one knows how to bring it up. They feel bad. They don't want to hurt your feeling. Maybe you don't want to hurt their feeling. But it doesn't go anywhere unless you're addressing it and talking about it and providing some space to communicate and share what those issues are. So emotional distress gets in the way, and I know I've mentioned this already, but just to be a little bit more specific, illness does provoke distracting worries. Am I healthy enough to engage in sex? You may have been told during chemo, don't engage in sex or be very careful. We want to be, careful in terms of infections. What about, will I hurt myself? And your partner may be asking this too, will I hurt her? Is sexual activity unhealthy? And I think I mentioned this too, sexual encounters almost become a test. Will it work this time? Am I going to try it out? Is it going to be okay? Is it going to be painless? Or is it going to be painful? And what happens then too with pain during sex is it becomes a distraction. You start thinking so much about, is this going to be painful? Or how do I look? How does my partner perceive me? What is he thinking or what is she thinking? You get so caught up in you get so caught up in this noise that you're no longer present. Your body's there, but mentally you're not present. And if you're not present within intimacy, there's no way there's going to be libido. There's no way you're going to feel arousal or be even enjoying what you're doing. You're so worried and stuck here. See if you can see my hand. You're so worried, and stuck here that you can't be present with your partner. So pain is one example of that. Anxiety is another example of that. Body image is another example of that. That really can get in the way of having a satisfying sexual relationship. The other distressor is depression. Depression is greater in cancer. Yes, this gets better over time, but there are periods of time where one feels down, where your cancer or treatment has affected your quality of life. Again, fatigue gets in the way. You may feel differently about yourself. Medical treatment, can contribute to depression too, especially hormonal therapy. Antidepressants, other psychotropic medication to help mood actually is another thing that gets in the way of healthy sexual function. There is definitely hope. There are many things that can be done to help with these issues. So I'm going to talk a little bit about what some of those are. With issues of desire, one thing that I will focus on is what would it look like if we take intercourse off the table and we focus on understanding your body and what feels desirable to you. And what feels desirable to you may look very different than what it did pre-cancer. So I like to talk about, expect desire to be flat or expect desire to be low going into some component of intimacy. Once you get started, though, usually Once you start connecting, there's this emotional intimacy, there's physical closeness, there's the connection with your partner. And it's these things that actually help to build desire. So arousal may come first, emotional connection, emotional intimacy, physical connection that help to build desire, that help to motivate one to want to engage in intimacy. The other thing I'll say too, if that feels too hard, you can jumpstart your libido. And what can you do about that? You can use things like fantasy. Maybe there was a past sexual experience that you remember as being very romantic or very arousing. You can use your mind to really think about that. Some women, really enjoy romance novels, erotic material like erotic videos. If that's something that you would like, I would say look for ones that are female produced because they're more likely to address sexual issues from the female perspective, the reality of females' bodies being very different from males and what's arousing to us as women. The other thing I'll talk about is, there's a whole body out there. If your breasts are no longer pleasurable, you no longer have sensation, you've got a whole body out there. Why not explore, get a chance to feel what feels good for you, change what that blueprint used to look like, change your sexual script. This is really the opportunity to do that and learn about your likes and dislikes, and maybe your partner as well, to learn about his or her partner and likes and dislikes as well, or as part of a couple. And I mentioned this too a little bit. The best intimacy happens when partners can communicate about their needs. Your partner does not know unless you tell him or her. I was just talking about this with one of my residents, and one thing we were talking about, a case, and within that, I really wanted to get the point across. How does the partner know what the patient feels? As a patient, or as a person, we assume our partners just know everything. They get it. They know what I like. They know what I don't like. Well, they may not. They may not. They may assume this is what you like. They may assume this is what you like because this is what he or she has always been doing. But if it's something you don't like or something you like a little bit more, it's your opportunity to communicate that in a very positive, supportive way that does not hurt feelings or does not cause anger. I get it. Sex is a very vulnerable, it makes us very vulnerable. It is very difficult to talk about, but there are opportunities, and you probably can think about some of those. But really communicating, providing the space, or when the door is open, use it. Talk about what's important to you as a person. For the disorders of arousal, which are, many times related to vaginal dryness, what's really important is using a lubricant. Not using one is like going down a water slide without water. And you understand what that pain feels like. So the importance of using a lubricant, and there's all different kinds. People say, oh, I got the Astro Glide at the store. There's a lot more out there than that. You could order from Amazon, for example. But the lubricants, there's different kinds. So there's water-based lubricants if you want, you prefer very natural. With the water-based lubricant, the downside with that is that it typically dries easy, so you'll likely have to reapply it. And the water-based lubricants are very good for silicone objects. So if you're using anything like a vibrator, or if you're working with a pelvic floor therapist already and you're using a dilator, you may have to use a water-based lubricant. There's silicone-based lubricants too, and they last a long time, but they're not good with any kind of latex products because they will break those down. And there's even further natural remedies. The gynecologists I work with will often tell patients they can use what's in their kitchen. They can use coconut oil. Coconut oil is wonderful. It's a very nice scent. A lot of my younger clients will use the coconut oil because they like the way it smells. They like the way it feels. There's no reapplying it. So there's lots of lubricants that are available. I strongly recommend, if vaginal dryness is an issue, that this becomes part then of your intimacy. This is not something you forget about. This is something that's always there at the side of the bed or wherever you keep your, your personal products. But it's really important to use, and it's important to apply the lubricant to your partner. If you're with a male partner, it should be applied to your partner's penis. If you're with a female partner, you're more than likely both have to apply it to the vulval area. The other issue, we as women are a little bit different than men. And another issue with arousal is there's not enough time. So what does that mean? There's not enough foreplay. For men, plus or minus a minute is usually enough time to produce some type of sexual response, like an erection. For women, women need at least 15 to 20 minutes of some type of foreplay to help move that arousal along. Sometimes women will say, my partner's not into that, or we don't have the time for that. And then I may suggest that maybe this is something you might concentrate alone before your partner comes into the room. You might use your imagery, think about other past fantasies or sexual experiences or something that may have felt very arousing to you. But I would encourage you to really slow down, give the body some time to respond, and really try to, I guess, kind of elongate that foreplay before beginning any type of penetration. You may or may not have heard of what's called Sensei Focus exercises. So what these are, this is a common therapy technique that I will give to individuals or couples as a homework assignment. So it's a series of like 15 to 30-minute exercises. As a couple, you agree not to engage in any type of penetration intercourse. This is not about that at all. This is really about reducing that anxiety, reducing any distress, finding more comfort in yourself or as a couple. So really what happens is you begin the exercises focusing on more heightened sensory awareness, touch, soft, smooth, rough, bumpy, focusing on those things. What do you see? Maybe what do you hear? What do you smell? Pressure, things like pressure, light or soft. All of these things that incorporate your senses. When you do that, what that does is it helps kind of very quickly bring you right back to the present in the moment. I was talking a little bit earlier about, we get stuck in this noise here, worried about, is this going to be painful? Is this going to happen again? What am I going to do if this happens again? Am I going to run away? How's my partner going to feel? It takes all those thoughts and just quiets them when you focus on the present moment. If you've done any of the mindful exercises that have been offered or meditation, all of those things really help you to focus on the present without judgment. And this is exactly what the Sensei Focus exercises do. Here, though, you're working with your partner. Each of you are taking a turn. So, for example, you as the patient might go first and you would be touching your partner. After 15 minutes, you would switch, and then your partner would be touching you. You're not talking. This is not about producing any type of arousal. This is just about getting comfortable, touching, reducing anxiety, and building that closeness. So a sample exercise would look like each partner softly touches the other. You can do clothed or unclothed. You're instructed to enjoy the company, not focus on arousal. Another exercise a little bit further down the line may be to touch each other unclothed, communicate likes and dislikes, maybe even focus on, what feels good. You really want to focus on what feels good to you, not what feels good to your partner. So this again is a tactic that helps bring you into the present. I don't know if anybody has seen this show on Netflix, Grace and Frankie. I think I've become a Netflix junkie now in the pandemic. I've never watched so much TV in my life in my free time. But anyway, there was an episode where they developed a vibrator that was used for older women. And I think what one of the premises here is, yes, this can become a very normal part of one's intimate life. And the other component that's really important, because orgasms change with time, as we get older, these things change normally. What may need to happen is stimulation may need to be varied. Maybe the use of a vibrator too can help with that. So there's lots of things on the market that can be used. Orgasms may take longer as part of aging in itself, in addition to treatment-related issues as previously discussed. What we usually do for pain and what, recommend, certainly addressing the emotional distress. Your doctor, your oncologist, your gynecologist, another medical provider may recommend seeing a pelvic floor physical therapist, which would, he or she would help to loosen those vaginal muscles, to help individuals work with a dilator if that's what's prescribed, to really, if there's been radiation to the vaginal area, again, there's scar tissue to really help work those issues out. Introduce lubricants in that. The other issue, and we talked about the lubricants, the other issues, you really want to avoid any deep thrusting if there's pain. And sometimes it's changing positions too that really can be helpful. One thing as women that we give ourselves, women as a culture, permission to criticize ourselves. How often do we look in the mirror and we find something wrong with us? So I think what's really important is that we replace that self-criticism with self-kindness. There's many self-kindness or compassion meditation tactics. And I'm sure they are doing these, or I know they're doing these virtually now. These are really important. We need to be kind to ourselves and compassionate too, and remind ourselves that we all are beautiful. I want to encourage you to ask. I spoke about don't ask, don't tell. It is important to ask. It is important to get help. The good sex fairy here does not come to your bedroom. So unfortunately, this is something you have to inquire about, or and hopefully get the resources, be made available, the resources to you. And just to introduce a little bit about what sex therapy is, it's a range of therapy techniques which may be used to initiate, restore, and enrich both the sexuality and the sexual components of intimate relationships. The goal is to help integrate new medical interventions into sexual routine. So things that I do often are provide psychosexual education, how the disease or treatment may have impacted sex, some of the treatments that I spoke about in here. Work with communicating about sexual concerns for self to a provider or self to a partner. Different behavioral interventions, and certainly things like cognitive restructuring. An example of that would be, focusing on what you can control, what actions we do, what attitudes, how we think, versus what we cannot control. There's random things, right? Things that happen in life. sometimes positive, meeting the person maybe that you are married to or in love with, and sometimes it's negative, like our illness or like an illness. These are things that we cannot control. What we can guarantee is that the outcome, and the outcome we can influence those through how we act or how we think and how we behave. Relaxation and stress management is extremely powerful. More and more research points to the benefits of doing this. Imagery rehearsal, just visualizing even a peaceful moment, maybe a favorite scene from a movie. Different muscle relaxation, stress management techniques, simple relaxed breathing that you may do in something like yoga. Mindful meditation, again, very powerful here. Certainly has been shown to help breast cancer patients, especially manage symptoms of fatigue, anxiety, fear of recurrence. It's also very beneficial with other cancers as well for men and for women. So some take-home notes, excuse me, on sex. Sexuality is a part of every person from before they are born until they die. Sexuality is a quality of life issue. Each person has a right to their sexuality, and emotional wellness is also very important in this journey. So I want to thank you very much for being here this evening, and I'm more than happy to take any questions that you may have.
Thank you. Other questions we have here, I guess, what about cancers that affect men? So I guess this is maybe tips or strategies for men that are dealing with these issues.
Yeah. So when I'm working with men, for example, say prostate cancer, the majority of them will experience erectile difficulties following treatment. I usually will work with patients and their partners, again, education, explaining what to expect, explaining what the goals to recovery may look like. For many men that may not be returning to the same level of erectile ability that they had before the diagnosis, but it may look like something very different. For men, unlike women, there are sexual aids. So there's a group of drugs called the PDE5 inhibitors, like Viagra, that are often recommended as part of penile rehabilitation following prostate cancer to really help strengthen the blood flow to the penis and produce some type of erection that may be firm enough for penetration. So there's a medical treatment approach in terms of medication that is not available for women, but for men that certainly is available. I really would encourage them to talk with their doctors about what may be the best option for them, because that's just step one. Step two is, there's penile injections to produce erection. There's a step 3, step 4, and step 5. So there's many things, for men too, like women, there's this suffering in silence. There's, a partner saying, don't worry about that. You're great. You're alive. This is all that I'm concerned about. And that partner is not saying, and no one's not saying, like, this has got to be really hard for you. This is really different for you. How can we still be sexual? And that still being sexual may not include intercourse, but it may include what I call outer course. Being sexual in other ways. Again, that whole body that's there, many things can feel arousing, feel good, feel comfortable, feel emotionally connected with partners.
Sorry, I was muted. Another question that we hear, so there's this individual, both the husband and themselves have had 3 cancers in the last 6 years. They're struggling with body image issues themselves. And for this person, the body changes that he has experienced, which include weight loss and dramatic structure changes. They'd like to know how they can change their attitude regarding his body changes.
Yeah. So it takes time, right? It takes acknowledging that there is change. and acknowledging that the self you are today is not the self you were before treatment. And the goal may be to get as close as you can to that person, but you may not get to that person. So acknowledging that your self, working slowly to accept the changes as part of you now. I hate the term the new normal, but I like to use, this is more of who you are right now. We don't know. No one can predict how close you're going to get to that person you were before that. But certainly it's very difficult to deal with things maybe that you never had to before, urinary incontinence, some leakage with sex, changes in how you experience things like orgasm. All of these things are very normal as part of treatment recovery. As a couple, it's working together, and something like the Sensei Focus exercises would be something that I definitely would recommend. Take the pressure off of having penetration sex and focus more on communicating, touching for your own pleasure, and changing what that blueprint or what that sexual script looks like for yourselves today as a couple.
Another question we have here is, what would be an example of PFPT?
So PFPT is a pelvic floor physical therapist. They are usually at most major medical centers. So physical therapist, right? We can think of what a physical therapist does. Oh, they work with somebody after they've hurt their back or they've broken a bone. They really work to rehabilitate that muscle or, that body part that has been damaged. A pelvic floor physical therapist will work specifically with the pelvic floor. So I guess it would be kind of your waist down, the pelvis area. There are, hundreds of muscles there. So a pelvic floor therapist will work to if there's scar tissue. So it may be with an internal exam or internal massage, I should say. It may be on an external, if there's scar tissue, from surgery, they will work those issues out through some type of deep massage. For example, they may teach patients how to do Kegel exercises to help with things like incontinence, to relax their abdomen, their pelvic floor through relaxed breathing. So they really do a whole host of different types of things.
Okay. I don't think we have any questions. I know we're coming up to time, so if anybody has one final question or comment, this will be your chance.
And I'm happy to take any questions by email too, Michelle. You please feel free to give out my email. Sometimes that's easier to do too. Or if I can direct you to some resources. Lots of great books out there too about intimacy after cancer for men and for women. Really helps to normalize, I feel, what you're experiencing, maybe give you some further ideas and suggestions too.
Okay, wonderful. I'll include your email address then when we send them the link to this presentation. So I just want to thank everyone who joined us for today's program. I also want to thank you, Dr. Siston, for again sharing your expertise with us and for such a wonderful presentation. So again, this presentation, the recording will be sent to everybody tomorrow. Along with her contact information. And thank you for joining us today.
Stay warm. Yeah, stay warm, everyone. Yes, yeah. Have a good evening. I'm glad no one's driving home now. Okay. Bye-bye. Good night.